Hello friends, welcome to Quikdentistry, solution for your dental subjects from first to final year. Subscribe the channel to learn your subjects fast and don't forget to press the bell icon for new videos. Hello everybody, in our last video lecture we had studied about classification of thyroid swelling. In this we are going to study about simple goiter and toxic goiter. Simple goiter, also known as physiologic goiter, it occurs during puberty and pregnancy, causes iodine deficiency, antithyroid drugs and brassica family. ये प्यूबर्टी और प्रेगनेंसी में जब मेटाबॉलिक डिमांड्स हाई रहती है तब TSH स्टिमुलेट करती है थायराइड ग्लैंड को और डिफ्यूज हाइपरट्रोफी और हाइपरप्लेजिया कॉज करती है. कॉम्प्लिकेशन है डिस्पनिया, डिस्फेजिया, वॉइस चेंज और MNG. ट्रीटमेंट क्या है? थायरोक्सिन 0.2 mg पर डे टू सप्रेस TSH. आयोडीन डेफिशिएंसी गोइटर हिली एरियाज में होता है. इसे हम आयोडाइज सॉल्ट से ही ट्रीट करते हैं और अगर इसे हम सही टाइम पे ट्रीट ना करें तो MNG हो जाता है. मल्टीनोड्यूलर गोइटर कैसे बनता है? पहला स्टेज है डिफ्यूज हाइपरट्रोफी हाइपरप्लेजिया हो जाता है जिसमें कि TSH लेवल बढ़ के एक्टिव फॉलिकल्स, फिर नेक्रोज फॉलिकल्स और नोड्यूल्स बन जाते हैं. अब हम पढ़ेंगे मल्टीनोड्यूलर गोइटर के बारे में, जो कि एक बहुत ही इंपॉर्टेंट टॉपिक है. इसमें से क्वेश्चंस पूछे जा सकते हैं. एक इम्पॉर्टेंट क्वेश्चन ये है कि इसकी इटियोपैथोजेनेसिस, क्लिनिकल फीचर, इन्वेस्टिगेशन एंड ट्रीटमेंट बताइए मल्टीनोड्यूलर गोइटर का. इन दिस डायग्राम वी कैन अप्रिशिएट द नोड्यूल्स प्रेजेंट इन द नेक. देयर इज एन enlarged swelling and there are few nodules that we can see in the neck. This is multinodular goiter where nodule formation occurs. So what is multinodular goiter? It is the end stage of diffuse hyperplastic goiter. Hyperplastic means increase in number of cells. Clinical features are common in females 20 to 40 years, swelling in the neck, hard areas such as calcification, soft areas necrosis, sudden increase in pain such as hemorrhage. Most common site of nodule कहाँ होती है? At the junction of isthmus with one lobe. So what are the complications? Calcification and long-standing sudden hemorrhage. A patient can develop secondary toxicosis. 8 to 10% of MNG can cause follicular carcinoma. Management, investigation of complete blood picture, X-ray of the neck, indirect laryngoscopy. Sonography, FNAC, isotopic scan. Now what is isotopic scan? It is done by using tracer dose of radioiodine. Here I am drawing 3 thyroid glands. Here in the first one, the gland does not take up any isotope but the nodule takes it up, which is the feature of autonomous solitary toxic nodule. Here the normal thyroid tissue is suppressed. Second one, warm nodule. Entire gland takes up isotope. This is typical Graves' disease or primary THYROTOXICOSIS. In the third one, this is a cold nodule which does not take up any isotope. 10% of cold nodules are malignant. So the first one is hot nodule, second one is warm nodule, and the third one is cold nodule. Treatment: total thyroidectomy, complete removal, near total thyroidectomy, removal of whole tissue except 2 grams, subtotal thyroidectomy, removal of whole tissue except 4 grams at one side. External goiter is often MNG with lower border unseen, rarely from ectopic thyroid tissue. What are the clinical types? Substernal, which is most common, intrathoracic, no thyroid is seen, plunging goiter, visible during coughing. Clinical features of retrosternal goiter: suspected when lower border is not seen, dyspnea, dysphagia, engorged neck veins, Pemberton's test. Treatment: investigation is similar to MNG. Isotopic scan is very useful. Treatment: surgical excision. Very rarely sternal split may be necessary. Toxic goiter is divided into primary thyrotoxicosis, secondary thyrotoxicosis, solitary nodule, and other causes. Toxic goiter. Anything in excess is toxic. Here, due to increased level of thyroid hormone, that is hyperthyroidism, toxic goiter occurs. Now let's begin with Graves' disease or primary thyrotoxicosis, which is a very important long note. So, etiopathogenesis, first of all, autoimmune. Administration of autoantibodies in circulation such as TSH receptor antibodies. It may be familial or thyroid stimulating immunoglobulin or exothalamus producing or female sex hormone, emotion, stress or at young age. Clinical features are 8 times more common in women than men. Weight loss, increased sweating, increased palpitation, heat intolerance, oligomenorrhea, eye signs such as exothalamus. Signs of primary thyrotoxicosis. First of all, signs in the thyroid gland are uniform, enlargement, smooth surface, gland is soft or firm in consistency, auscultation, root sound is heard, signs of CNS, tremor of tongue, hyperkinetic movements, always a moist hand, severe signs, pulse rate raised, palpitation, eye signs are prominent eyeball. Thyrotoxic myopathy, mild weakness of proximal limb, weakness of extraocular muscles, myopathy responds to anti-thyroid treatment, proximal limb muscles are involved, myasthenia gravis, periodic paralysis is found. Pretibial myxedema seen in patient with surgery or anti-thyroid drugs. Management of primary thyrotoxicosis. First, routine investigation such as complete blood count, fasting and postprandial blood sugar estimation, urine examination, chest x-ray, thyroid scan, next serum T3, T4 and TSH, next is thyroid antibodies are elevated, next sleeping, pulse rate is counted after patient is sedated with 30 mg of phenobarbital. And now the treatment of primary thyrotoxicosis. It is divided into 3 parts. Firstly, to restore the patient to euthyroid state. Second, to reduce the functioning thyroid mass. And third, to minimize complications. Under first, drugs such as potassium perchlorate, dose 200 to 400 mg daily. Propyl thiouracil in dose 200 mg 3 times a day can be given to patient who develop neutropenia. It is safe in pregnancy. Next is block and replace treatment. T3 20 mg up to 4 times per day or T4 0.1 mg per day is given along with anti-thyroid drugs, less incidence to develop hypothyroidism. Under the second part is subtotal thyroidectomy or radioiodine therapy. Under to minimize complication is good pre-operative preparations. Antithyroid drugs, carbimazole 10 mg 6 hourly, propranolol 10 to 20 mg 2 to 3 times a day, leucoxidine 10 to 12 drops 3 times a day. Thyrotoxicosis occurs as 25 to 40 years of age, long duration swelling, consistency firm or hard, surface nodular, root sound uncommon, pretibial myxedema never found. Treatment with antithyroid drugs and subtotal thyroidectomy. Solitary nodule, another short note. So its causes are 50% are colloid goiter of MNG, follicular adenoma, toxic autonomous nodule, carcinoma, thyroid cyst, thyroid. Solitary nodule, for management, we go for an iodine scan. If it's a cold nodule, then we go for ultrasonography. If it's simple cyst, we aspirate it. If there is recurrence, we go for surgical treatment. If it's bloody fluid, then we go for FNAC. If it's papillary carcinoma, then surgery. If follicular cells, then frozen section may be taken. Near total thyroidectomy is done. For hot nodule, we go for FNAC. If it's autonomous nodule, hemithyroidectomy. And for warm nodule, after FNAC, if it's part of MNG, then we go for surgery. Adenoma, again surgery. Thanks for watching.